Hi, this is Ahmed Alogaili and Manos Brilakis presenting case 224 for the manual of CTO interventions. This is a case illustrating the just marker technique for retrograde CTO crossing. The patient had multiple comorbidities, mainly esophageal cancer that he had been treated with chemotherapy and radiation therapy, and presented with angina, who was found to have 3-vessel disease with CTO of the LAD, diffuse disease of the right coronary artery, and a small diffusely diseased circumflex. His ejection fraction was 35%, but cardiac MRI saw viability in the anterior and the inferior walls. He was turned down for surgery and he was referred for percutaneous coronary intervention. Given the low ejection fraction, the complexity of the lesions, and the high likelihood of needing retrograde crossing, we decided to use prophylactic hemodynamic support with an Impella CP device. We also did a right heart and we monitored the pressure throughout the procedure. There were some bubbles going in, highlighting the importance of cleaning up the sheaths prior to injecting through any sheath. But fortunately, there was antegrade perfusion of the limb, which is reassuring that the patient will not get acute limb ischemia during use of the Impella device, at least during the procedure. This is the angiogram. We do have multiple lesions in the right coronary artery. Distal to mid right coronary artery, there is a lesion in the PDA. There is retrograde filling of the LAD. And this is the assessment of the lesion with a dual injection. We do have essentially a blunt occlusion of the LAD at the ostium, at the takeoff of a ramus branch. We do have the distal vessel being diffusely diseased. There are two major diagonals. One of them is right next to the distal cap. We do have collaterals, mainly this epicardial collateral that is filling the LAD. But there are some septals, and we thought there might be some connection from the septals into the LAD. So the plan was to first try a primary retrograde through the septals, then try IVUS-guided puncture with the IVUS into the ramus branch, and if that failed, try to go retrograde through the epicardial. The concern there is ischemia, since this seemed to be the dominant provider of flow into the LAD. Before doing anything on the left, we decided to treat the right coronary artery, so we placed 3 drug-eluting stents and got a nice result in the right coronary artery. And then we tried to go retrograde. We tried several septals, but we were unable to cross them despite using the Suoh 3 and the Suoh Black. We tried to use IVUS into the side branch, but had difficulty finding the proximal cap because of severe calcification. And eventually, we decided to go retrograde through the epicardial. This is crossing using the Suoh 3 through a caravel microcatheter. Fortunately, the wire advanced fairly easily across the tortuosity. So very small moves and essentially waiting. The wire is moving with every heartbeat and eventually finds its way and goes into the LAD. We advance the caravel all the way and then we have a tip injection showing diffuse disease into the LAD. So at this point, our plan was to do reverse cart. However, trying to advance a Gladius Mongo retrograde, we had a lot of difficulty, and it looks like the wire was entering the extraplaque space into the proximal mid-LAD. So after multiple attempts, we tried workhorse wires, we tried Suoh 3, we tried multiple wires, but the wire kept on entering the extraplaque space. So we decided not to advance other equipment, but we decided to leave that wire, the retrograde wire, leave it in place and use it as a marker of the position of the LAD to allow antegrade crossing. And here we are. We see that the two wires, the antegrade and the retrograde, are next to each other. And we were then able to advance the antegrade guidewire that seems to be coursing along the side of the retrograde extraplaque wire. We then switched to a Gladius Mongo that advanced easily into a branch, and now we have the contralateral injection showing that the Gladius Mongo is into the diagonal branch. The next step was to use a dual lumen microcatheter. This was a Sasuke, and a workhorse guide wire to that advanced, but unfortunately it advanced into a septal branch. It didn't want to go into the LAD, but no problem. We left it there and then got the Sasuke again, and we did once again advancement of another guide wire through the Sasuke that was then able to be redirected into the LAD. So essentially, dual lumen microcatheter twice. One is to get around the diagonal, and the other one is to get around the septal, and eventually here, the workhorse wire is going easily into the distal LAD. We did intravascular ultrasound that did show intraplaque crossing throughout the left anterior descending artery. And then we placed a long drug-eluting stent all the way from the ostium of the LAD to the mid-LAD, jailing a wire in the diagonal branch, did proximal optimization, and got a nice result with T3 flow into the LAD. We did not lose any of the two diagonal branches. Patient hemodynamically was doing very well, so the Impella was weaned off and removed after the procedure, and the patient had an uneventful post-procedural course. So multiple lessons from this case. The first one is that PCI in a patient with multi-vessel disease who needs the retrograde crossing, it's best to fix the donor vessel before doing the retrograde approach. So in this case, we did perform PCI of the right coronary artery before attempting any retrograde crossing of the LAD. Second lesson is about the way of retrograde crossing. In this case, we advanced the retrograde wire through the epicardial collateral, but we kept on entering into the extraplaque space. And we did not want to do reverse cart early because we were concerned we're going to lose two fairly large diagonal branches. So instead, we used the extraplaque retrograde guide wire as a marker of the position of the LAD. And by doing that, we were then able to advance an antegrade Gaia wire that was exchanged for a Mongo, crossing antegrade intraplaque into the diagonal. So multiple challenges in this case, including both the crossing of the septals that failed, the epicardial collateral crossing was successful, but the main thing is to change rapidly the technique. We did not do reverse cart. Instead, we used a just marker technique, which is used relatively infrequently, but that was successful in recanalizing the LAD, maintaining patency of those two major branches. Thank you.